All right, great. It is 12 o'clock, so let's go ahead and get started. I want to welcome everyone to Medical Grand Rounds at the University of Colorado. Very happy that we are back in person. We're here in RC2 in the Krugman Conference Hall. We'll continue to broadcast via Zoom probably for the remainder of time, but we do encourage people to come in person, and I've been going to all of the divisions, and I appreciate seeing all the divisional members who are here in person today, so thank you for doing that. And please, if you're not here, consider coming back. It's more fun in person. Next week is a little bit of a teaser. Dr. Gene Kuttner, our Chief Medical Officer here at UC Health, is going to talk about leading in complexity. And then on November 2nd, we have an outside speaker. We haven't had an outside speaker in several weeks, Michael Blaha, who's going to give the Robert Eckel invited lectureship this year from Johns Hopkins Hospital, talking about reducing risk factors in ASCVD. As a reminder, CME and mock credit is available for all grand rounds this year. Please use the QR code that you can see on the screen. Sorry, I probably shouldn't do that right as I say that. So go ahead and pop that up and I'll move forward in just a second. And as a reminder, most questions will come from our live audience, but we will continue to have the Zoom chat open. Please use the Q&A link. Our Chief Medical Residents, thank you very much. We'll be monitoring the Zoom Q&A. Now I am pleased to welcome Dr. Jen Adams to Medical Grand Rounds. Dr. Adams is a professor in the Department of Medicine in the Division of General Internal Medicine with a clinical practice at Denver Health at the Westside Family Health Center, where she has been a practicing physician for a number of years. Since 2018, Jen has also served as the Assistant Dean of Medical Education, the Director of Clinical Curriculum, and since 2022, just this summer, she is now the Interim Associate Dean at the Colorado Springs Branch campus. Her undergrad work was completed at Colby College, where she graduated magna cum laude. She did her medical school here at the University of Colorado, where she was an AOA student, and then residency at the University of California, San Francisco in their primary care track. And we were lucky, obviously, to recruit her back to Colorado shortly thereafter. Dr. Adams has been a leader in education on this campus and nationally for a very long time. And I really am thrilled to hear what she's going to talk about today because it directly affects what the state of medicine and medical education is going to look like here going forward. Her rise to being in charge of the many curricular things of which she is in charge, including her deanship in the Springs, has been the result of an incredible amount of hard work, dedication, and time, and her development as an expertise, someone who has expertise in education. In addition to the roles that she holds currently, which I just mentioned, she's also on the executive committee for reform, advising the Senior Associate Dean of Education on all aspects of the curriculum of medicine. She has been the Director of Education at Denver Health. She was the director and founder of the Denver Health Longitudinal Integrated Clerkship, which obviously led to what's going to happen in the entirety of the campus. She was also the director of the Westside Resident Continuity Practice when she was an associate program director in this residency. Her work has led to over 200 publications, posters, workshops, and nationally invited speaking engagements. She really is seen as somebody who leads in this space nationally. And of course, she's received a number of awards. She was a winner of the Elaine Cleary Award for Medical Student Teaching. She was also the very first winner of our House Staff Award for the Attending Teacher of the Year. She was in 2019 the Charles Menton Award winner for Outstanding Service in HIV Primary Care, as well as the AMA Women Physicians Inspirational Honoree. And then in 2020, she was the Outstanding Clinical Teacher for the Kaiser Family Foundation. And then finally, this culminated in being named the Chancellor's Teaching Recognition Award for the entire School of Medicine in 2021. Really is an honor to have Dr. Jen Adams here with us today.
Thank you so much, Jeff. That was an incredibly kind introduction. I am incredibly thrilled to be here today to talk to you all about our School of Medicine curriculum reform and this journey towards longitudinal integrated clerkship. So let's go ahead and dive in. So I'll begin by stating that I have no financial disclosures or conflicts of interest. However, as Jeff mentioned, I developed and ran the Denver Health Longitudinal Integrated Clerkship for the last 10 years. So in this role, I believe I've developed a pretty considerable bias about the value and benefit of this model of clinical education. These photos capture just a few of the really fun moments that I've had over the last 10 years with my students and faculty in this model. I also want to begin just with a few words of gratitude and acknowledgement for the CU curriculum reform team who has shared equally in this work. There's a huge group of people behind what I'll be presenting today. I'm grateful to their collaboration and permission to share our vision and work around the CU curriculum reform. In particular, Shanta Zimmer, who's our Senior Associate Dean for Medical Education, has led this vision and this team who's worked really pretty tirelessly over the last 5 years to bring these ideas to fruition. So I want to give her a particular shout out. There's a huge group of people behind this work. So also pictured here are a few of my colleagues that have worked really hard with me. And I do just want to acknowledge the large group of people behind this that I'm presenting on behalf of today. Pictured below that are our most recent class of Denver Health LIC students to graduate from the CU School of Medicine. As I've sort of alluded to already, the work on the Denver Health LIC has been some of the most fun and fulfilling work of my career. The graduating students here are just a snapshot of some of that work. I'll be sharing lots of stories of our students, faculty, and patients today. Everyone featured here today has given me permission to share their stories and images in my presentation. And then finally, I just want to acknowledge and express my gratitude to my family. The boys pictured in the top right there camping last summer. They've put up with quite a lot in terms of long hours over the last 5 years of our curriculum reform. So with that, let's jump in. I'm hoping by the end of our time today, you'll be able to define a longitudinal integrated clerkship and the key aspects of this learning model. You'll be able to describe the value of this LIC model and how that translates into our rationale for this big change at the CU School of Medicine. And we'll explore together some of the unique teaching opportunities in this LIC model as we have embraced a pretty significant change in medical education here at CU. So let's begin with a case. This might be you, or maybe just a friend or someone you've heard about or know. But let's say this is a Department of Medicine faculty member who is finishing up a long day, maybe in clinic, and about to get signed out for the team she'll take on tomorrow morning on any one of our teaching hospital wards. So far, things sound pretty good. A team of 14 inpatients, one highly competent medical house staff member, 2 fantastic interns, one highly enthusiastic acting intern, and a medical student who, rather than being on a traditional hack clerkship, is starting her immersion in internal medicine in her LIC. So this gives you pause. What's this LIC? Maybe you haven't heard of this before. Maybe you haven't even heard of the large curriculum reform that the school is undergoing. So you pause for a sec and wonder what you're supposed to do with this. So I'm going to pause here and tell you about what an LIC is all about. I'm looking out over this audience and know a number of you have a lot of familiarity with the LIC model, but some of you may be hearing about this for the first time. So I'm going to kind of start with the basics and then we'll dig in a little bit deeper as we go. So what is an LIC? An LIC is an innovation in clinical education in which we move away from the traditional block-based rotations. This is probably the model in which you trained in. It's certainly the model in which I trained in. When students complete a block of specialty-specific training, let's say they start with internal medicine, they do internal medicine for 8 weeks, and that's all they do, day in and day out, and then they take a specialty-specific exam at the end of that. And then they may move on to something else, psychiatry, pediatrics, something else entirely. And they may not revisit internal medicine unless they are thinking about that as a career, in which case they do an acting internship. Or they may not go back to it all until they're studying for the boards. In contrast, in an LIC model, we place students with longitudinal preceptors in each of these core specialties, and they work with them periodically throughout the week, and they stay with that preceptor throughout the entirety of their longitudinal clerkship year. This allows them to develop continuity with their patients, with their faculty, and with their community, because they're placed in a single institution or a single community for the entirety of their year. This allows them to meet their clinical requirements across each discipline simultaneously. So how does this actually work? That's sort of the theory behind it, but I think the complexity is in how this actually comes together into the students' learning. So this might be a sample schedule for a student in their LIC. The student has preceptors in each of our 7 specialties. They also have a learning seminar, which they attend once a week. That's shown here on a Wednesday afternoon. Students are in small groups, learning together within their LIC cohort. Most of their learning is case-based, so in a team-based learning format, which is what we've chosen. They also have additional inpatient or specialty-specific training woven in through their longitudinal patients, and I'll talk about that more in a moment. They have flexibility to follow these patients through their extended learning time. So these are sessions each week that are flexible. They're meant to be self-directed so that students can follow these patients or follow their learning wherever it may take them. In addition, students participate in inpatient immersions. So these are essentially structured like the old inpatient clerkships that we all are used to. Students are placed on inpatient ward teams focusing on learning to care for acutely ill patients. Additional goals include focused work on oral presentations, transitions of care, team-based care, and ultimately just kind of learning to function on the ward service so that when they do have longitudinal patients that are admitted to the hospital from other settings, they actually know what to do when they show up. So they can join the team somewhat seamlessly, know how to round, know what the team needs, know how to write orders, know how to write notes, and flow seamlessly into that care environment. This is true of all their other specialties as well. So they'll also spend concentrated time on the surgical service, OBGYN, pediatrics, and psychiatry. In addition to emphasizing what this immersion is all about, I also like to emphasize what it is not. So it is not meant to be a condensed clerkship. Our students cannot be expected to learn all of internal medicine in 4 weeks when they used to have 8 weeks to learn all this material. So I don't want you to think that we've tried to squeeze all of internal medicine into 4 weeks. Remember that our students are also working weekly with our outpatient internal medicine preceptors and have that opportunity to continue their learning likely before and after their internal medicine immersion. They also have all their longitudinal patients that are going to interface with internal medicine throughout the year. The final key component of the LIC is the patient panel. A critical objective of the LIC is for students to serve as care providers, as advocates, as navigators for their patients throughout the clerkship year, as they attend visits, admissions, procedures, and deliveries with these patients. Students have a minimum number of cohort patients and are expected to follow these patients over time and throughout care venues throughout the year. So I think this is really the unique aspect of the LIC model. Students get to experience a healthcare system from the perspective of the patient, seeing our healthcare system function and sometimes not function so well as they learn to navigate on behalf of their patients. So this really gives our students the opportunity, for example, to see a patient in internal medicine, see them be discharged, see that transition of care. Sometimes that works flawlessly, sometimes it doesn't. And then maybe the next time that patient needs care, she's pregnant, so they're going to OBGYN. And then the next time, maybe they've broken a bone, so they're in orthopedics. And then the next time they're in the emergency room. So the learning really becomes about the patient, not about the siloed specialty in which the doctor is practicing. Instead, it's about where the patient needs their care. So the title of this book tells us change is good, but I also want to say that change is hard. And you may be asking yourself as you sit here and listen to all this, why are we actually doing all this work to completely change our medical school? Seemed like the old model worked out okay. We're all sitting here. We got through the old model and turned out to be pretty decent doctors, I think. But what I'd like to do today is to try to tell you a little bit more about the why and the evidence that compelled us to change all of our clerkships to the LIC model. I also want to recognize here that in our curriculum reform, LICs are just one element of our change. So my area of expertise is around our LICs, and that's the part of this change that I've led. But as I mentioned, there's a much larger team working on our curriculum reform as a whole, and that group has really reformed and revised almost everything in our curriculum. So we're going to focus just on the LICs today. So I want to tell you about the evidence behind this change, both what's been demonstrated in the literature and also about some of our experiences here at CU. Most of you, as I mentioned, didn't train in this model and are adapting to something new. So I think that's the part that about change that can be really hard. I hope to get you excited or at least intrigued about the opportunities that come for interacting with our medical students and teaching in new ways that this model affords. CU is leading this change nationally, so there's a lot of excitement around that. I'm thrilled to share some of this excitement with you and hopefully get you engaged in some of the national excitement around that as well. So like the case that we started with, you may feel like this was dropped in your lap as of last night when you first heard about your LIC student who is in an LIC model. But I want to back up a little bit and tell you about our history at CU and how we arrived at this place where all of our students are now in LICs. It didn't actually happen all that suddenly. We've been working on this transformation for about the past 15 years. We've been testing the waters first with some pilots and then growing number of LICs over the past 15 years. In these early programs, their success, their popularity amongst our students, it was that gave us the knowledge and the confidence to know that LICs were really our path forward. So let me tell you a little bit about that journey. We began with an integrated family medicine and internal medicine clerkship, 3 months long in some of our rural sites, just a small handful of students in 2011. It was that led us to pilot the Denver Health LIC that I was involved in starting in 2014. This was our first fully integrated LIC. So the model that I described where students are comprised of all of their clerkships for a full length of the clerkship year. So we started that Denver Health LIC in 2014. That was followed quickly after by our VAST program. So this was a 6-month hybrid LIC at our VA hospital. All these programs laid the groundwork for the opening of our branch campuses in Colorado Springs and Fort Collins, both of which started with all their students in a fully integrated year-long LIC program. Colorado Springs in 2016, and then Fort Collins in 2020. So it was this foundation on which change was built. So I'm going to return to telling you towards the end of my talk a little bit more about what our final iteration of this change now looks like at CU. But let's go back first and focus a little bit more on the why. So let me back up even further historically beyond where CU began with this journey into the 1800s and talk a little bit about the history of medical education. I promise that we won't spend all of our time talking about a history lesson today. So in 1850, we find the first recommendations around medical training. At this time, it was suggested that medical doctors, just suggested, the medical doctors participate in an apprenticeship to learn the skills of the trade. I think it's actually kind of interesting and ironic that we've come full circle with our LICs, returning to understand the apprenticeship of this apprenticeship model. Then at the turn of the century in 1900, Osler and Halstead started making recommendations around training practices that we now just consider to be truth. Participating in direct supervised patient care, providing our trainees with mentorship and providing them with opportunities for active learning rather than just reading about medicine in a book. It was then in 1910 when Abraham Flexner published his now famous report recommending that medical schools have a similar structure in which they provide 2 years of basic science learning followed by 2 years of clinical practice. So that led to a massive reform in medical education. Basically, every medical school ended up adopting this. Those that didn't comply eventually were eliminated. The University of Colorado took on this model and basically stayed there for the next century, as did most medical schools. It was then in the 1960s to 2000s that medical schools faced increasing regulation and accreditation standards. This was necessary, this was good, but I think the unfortunate byproduct of this was that our students, our trainees, were moved further and further from patients and moved further and further from the faculty mentorship and apprenticeship model that was originally described as essential for their training. Interestingly, it was actually during this time period that we saw the first emergence of LICs. So even though we think about this being a relatively new thing in medical education, the first LIC actually appeared in 1971. Then in the next 30 years, these LICs produced really impressive, successful data about student learning and also about workforce outcomes. The scholarly evidence base for LICs then accelerated in the 2000s after David Hirsch and his colleagues published an article in the New England Journal describing the concept of educational continuity. The importance of apprenticeship was then kind of manifest again as educators started to think much more about relationship-based education, relationship between students and their patients and students and their teachers. It was about a decade ago, so in the early 2000s, that we saw increased interest around competency-based education, and simultaneously, the number of LICs in this country started to explode. That was right when CU started to develop interest in this as well. I think these two movements go hand in hand. We can think importantly about competency and how really to assess that in our students when we have these longitudinal relationships that allow our teachers really to think deeply and watch our students carefully as they develop in their skills. Yet at the same time, what we started to see was increased pressure from our clinical systems around efficiency and regulations in the hospital, pressures that really demanded time and effort from our educators around those regulations instead of on best practices in education. So I think that brings us to this crossroads. We're caught right now in a healthcare system where our students, unfortunately, I think become bystanders really frequently. Bystanders to the priorities of our healthcare system, where importantly, and I'm not suggesting that this isn't a necessary priority, but the healthcare system really is forced to think about care efficiency and productivity. I think that limits our students' ability to participate directly in patient care. They become observers of care more often than we would like, and they become distanced from their teacher because of the fragmentation of clinical care. So I think we can continue on this path, or we can look for a new model. If it's not obvious, I think we should look for a new model, one that emphasizes authenticity. Authenticity for our students within this healthcare system, where we can find opportunities again for them to have continuity with their teachers, develop meaningful relationships where we can truly measure competency, and where we can place them meaningfully in communities where they can remain and truly come to understand the healthcare system where they're working in. So I think the LIC model allows us to look for this new path. At the University of Colorado, we stood at this crossroads in 2017 when we began our curriculum reform. The initial steps of this process led us to be charged by Dean Riley and by Shanta Zimmer with a blue sky approach. Dig deep, look at all the literature about clinical education and figure out the best possible approach. So we dug into the evidence, and I think what became really clear in our initial research was that the evidence in favor of moving this very traditional medical school, we were 2+2, just like Flexner prescribed, to an all LIC model really couldn't be ignored. I'm going to briefly summarize the high points of this literature, and then we are going to dig into some of, I think, the more important studies a little bit deeper. Students prefer learning in this model and are more satisfied in LICs than they are in traditional blocks. I think we already knew this based on our experience with those early LICs. What we were finding is that we continued to develop more LICs and offer more spots, and student demand continued to outpace that. So we could not provide enough spots in our LICs to satisfy student demand for that. Students also perform slightly better academically. The literature is sort of quoted as being non-inferior, but if you look at it, there's sort of trends towards increased or better performance on academic measures in LICs. So this really shouldn't come as a surprise. If you look at the learning theory behind this, when you create spaced and interleaved learning models such as an LIC, you should see better retention of material and therefore better performance on traditional measures of academic retention, things like standardized exams. Longitudinal relationships with faculty preceptors meant better coaching, better teaching, better mentorship, and really fostered this growth mindset. This is what we want our students to do. Instead of focusing on the exam score at the end, to really think about the process and learning to be the best physician they can be. Another lesson we learned was that our faculty preferred teaching in this model. So this was another sort of unintended consequence of our early LICs, is that we had a lot of faculty jumping ship. So when they had the opportunity to teach in an LIC or teach in a block, once they tried teaching in the LIC, they preferred that, and we had a huge attrition rate from our blocks to our LICs. We also found that we could support and nurture students' relationships with patients. This turned out to be to the enormous benefit of students and patients, and ultimately results in increased empathy and patient-centeredness. This persists, as I'll show you some of these studies, long after completion of the LIC program. Honestly, I think this was the clincher for us. If we could create a curriculum in which our students came out equally academically strong, but we're going to be more empathetic and patient-centered, how could we not choose that path? This is the doctor we wanted to create, right? And then finally, we sought to think about how our future LICs might focus on healthcare and workforce needs, meeting greater societal demands through our new curriculum. So in the end, the choice for us really became pretty obvious. If we could have a curricular model that was better for our student learning, our faculty preferred it, and allowed us to think forward to meeting healthcare needs of our community, we had our answer. CU was all in for LICs. We decided to take this huge leap, making us the first medical school in the US to transition from a traditional block-based model to all LICs. So let's dig into this evidence in a little bit more detail, as well as some of the stories that I think have compelled our embracing of change, specifically of this LIC model at CU. So the outcomes related to student experience and learning within the LIC are by far the best documented. There's actually a pretty large body of evidence around this, so I'll summarize this for you. But I think equally important are some of the newer frontiers in the LIC literature when we start to think about how this model impacts our faculty and how we teach, how we can impact patient outcomes, and how we can think about the impact on healthcare systems and communities as well. So I'll start to touch on some of those outcomes as well. So starting with our students, as I mentioned, there's actually quite a bit of literature demonstrating that students in LICs compared to those in traditional block rotations perform equally well, if not slightly better in terms of academic achievement. So this includes how well they perform on standardized exams. The ones we give are the NBME shelf exams, USMLE Step 2, academic, acting internships, and ultimately the residency match. These data come out of numerous medical schools across the US and internationally and have been replicated here at CU as well. So I get lots of questions about the residency match, so I thought I would just put this here to try to answer some of those questions. We now have 6 years worth of outcomes in terms of our own CU students entering the match. Our students have now matched in nearly every specialty successfully. Inconsistent with larger School of Medicine trends, internal medicine is the most popular specialty that our students go into. The other specialties tend to match up pretty consistently with our student body as a whole. Beyond those academic outcomes, I actually find some of these non-cognitive measures to be even more interesting and more compelling in terms of a rationale for change. LIC students have been shown to measure higher in terms of validated measures for patient-centeredness and increased empathy at the end of their LIC year. So when you take a group of students and measure how they look in terms of these two measures, when they start in LIC, they're similar, but at the end, there's a split. And I think what's even more compelling is that these differences persist over time. So this was a study that came out of Harvard Medical School, where the Cambridge Integrated Clerkship was one of the first LICs in the US, and certainly one of the ones that we've seen the most data come out of. As you can see, there wasn't a significant difference in these students when they began, a significant split at the end of their clerkship, and then up to 6 years out, so post-residency, into practice, these differences persist, suggesting that the LIC had a profound and persistent difference on their patient-centeredness and their empathy. Again, I want to emphasize that I think this is the most important reason, or the most important why for our transformation here at CU. So I want to think next and pivot a little bit to talking about our faculty. The student outcomes, I believe, are clear that we can do better for our students by transforming our curriculum. But equally important, I think, is the impact of curricular change on our faculty. You're the ones doing this work and educating our students day in and day out. So some of these faces may be familiar to many of you here in the audience. Rewind a couple of years ago, and the now Kira Gresh, one of your second-year residents, was working with her LIC preceptor, Dr. Yasmin Sakro at Denver Health. In fact, she'd been working all year with a patient on his chronic medical conditions, fighting hard to develop the rapport and trust that would allow this patient to make meaningful change in managing his chronic complex diseases. So it was pretty late on a Friday night when I got this text from Yasmin, who had just attended a theater performance produced by this patient, who had then invited her and Kira to attend his opening night. When the show finished, Kira and I sat transfixed in our seats. Our patient found us and says, "So this is where I feel most alive. This was the highlight of my clinical and educational career coming together in this incredible moment. Thanks to LIC for making this moment, this opportunity happen." So I think this story illustrates why our faculty find this model so rewarding, and our retention of faculty is so high. They really adore the long-term relationships with their students and see real value in student contribution to care. That's actually a pretty remarkable statement. I don't think we often think about how our students contribute to our care. They often are in this sort of taking relationship where we give them the education and they're not giving a lot back. but these are students who are really meaningfully contributing. Our faculty also describe this really unique benefit in the LIC where they're able to develop a community of practice amongst the other preceptors who are also taking ownership in teaching that particular LIC student. I want to acknowledge, I think there will always be time pressures and stressors in clinical practice. There's always going to be issues around cost and access. This is sort of the reality of our clinical environment right now. But I think the LIC model uniquely allows the joy of teaching to outweigh these factors more than we've been able to achieve in a block model. Teaching is hard. I think the shifts related to this curriculum reform around the budgetary changes and just change in general have been hard on our faculty. But I think it's these relationships with students that really allow us to see the ultimate payoff of curriculum reform. So back in 2014, in the inaugural year of our Denver Health LIC, I conducted a study surveying our LIC preceptors, most of whom had taught in our traditional block model clerkships previously, and asked them to reflect on a number of questions about their experiences teaching in both models. I think some of the more notable results come from them describing what their experiences were like related to teaching satisfaction. So 85% of these faculty reported that they were overall satisfied with the LIC model after doing it for a year. Perhaps even more remarkable than that, though, was that 57% reported an overall increase in their job satisfaction. So think about that for a minute. 57% said that because they had a student with them 1/2 day a week, their job satisfaction increased. So they were happier going to work every day because of this student. 94% reported higher satisfaction and reward from teaching in the Denver Health LIC compared to traditional block clerkships. So this explains our attrition problem, why our faculty no longer wanted to teach in the blocks and wanted to teach in the LICs instead. 85% in that first year came back to teach a second year. It's never dropped below 90% since. In some, I think findings like this have led me to believe that LICs are a path forward, not only for our students and their learning, but a path forward in recruiting and retaining excellent faculty in our current clinical environment when education is not prioritized frequently next to the clinical metrics that we feel a lot of pressure around, and resources to reward our faculty for their contribution to our educational mission are severely limited. Finally, I want us to think beyond our students and faculty to the patients themselves. These are the ultimate consumers of our educational product, right? So first, I think we need to reframe our idea about what the medical student role. In block models, students are often at the whim of the team structure, shift work, resident duty hours. They're forced to be opportunistic in their learning and often relegated to observing rather than having truly authentic roles in ownership of their learning and ownership of patient care. In contrast, in the LIC, what we're aiming for is that they develop a longitudinal partnership with faculty. They develop a shared responsibility for their patients and earn progressive trust. So through this developmental process, students should become true members of the team, take on authentic care responsibilities, and become navigators and advocates. They start to understand care holistically and develop responsibility over time and place to individual patients. So learning itself starts to revolve around the patients they're taking care of, not the medical team they happen to be rotating with that week. So let's just think for a minute about the amazing potential this may have for our patients. Not just someday off in the future, 6 years from now, as the studies have shown, when these students become those amazing, empathetic, patient-centered doctors that we believe we can train, but right now, when they're still medical students. In another study conducted at Denver Health, we interviewed patients followed by LIC students and asked about their experiences working with students over the course of their LIC year. What we found from qualitative analysis was that patients highly valued their therapeutic alliance with their LIC students. They were able to voice that their patient experience was better. They liked coming to interact with the healthcare system better when they knew their LIC student was going to be there. They reported that their health outcomes were better. They felt there was tangible improvement in how they felt and how they did in terms of their health because of that student. These patients described a lot of failures in the healthcare system, but felt that having a student there mitigated some of that and helped solve some of those problems. They saw their students serving as bridges between their care providers across specialties, across settings. This was so impactful that patients, I think this was one of the most surprising things that came out of this study, was that our patients really experienced a pretty profound loss when the student left. This was despite the fact that their doctors stayed on, right? So they had continuity of care in the healthcare system, but their student left, and our patients saw this as a real loss. So these were a couple of the quotes that I thought really were illustrative of these points. So one patient says, the idea of taking the medication to actually settle things down really impacted me. I don't even know if he knows that he made me comfortable enough to change my mind on something like that. So this is a patient saying how the student's presence and their counsel led him to do something differently, to take a medication he might not otherwise have taken. Another patient says he snuck in to see me at the ER. That made me feel like I mattered. So this is a patient who had a student running around the hospital system as we expect them to do, showing up in the ER. Our care providers don't usually do that. I'll tell you, as a primary care provider, I am not running from my clinic to the ER to visit my patients typically, but the students are. That's the expectation. That's what they're supposed to do. And that makes this patient feel seen, like they matter. Another really important and telling study comes to us from the VA in Minneapolis, where the University of Minnesota runs another really wonderful LIC program called Value. In this study, patients were randomized actually based on whether they had an LIC student or not. So they run their LIC a little bit differently than we do here, and the students are assigned a panel from the outset. Here at Colorado, we allow students to find their own panel as they progress through the LIC year. In this program, students are assigned their patients from the outset. So what they did in terms of the design of this study is they categorized their patients by disease severity and then randomized them to a provider who had an LIC student or to a provider who did not have an LIC student. And then at the end of the year, they did a telephone survey and asked them a bunch of questions about their satisfaction. And I think these results are really astounding. What they found is that those patients who had a provider who had an LIC student reported greater satisfaction with the explanations provided by their LIC or by their PCP, had greater satisfaction with the provider's knowledge of their personal history, and greater agreement that the provider was looking out for their best interests. And most importantly of all, they had their patients rate on a scale of 1 to 5 how satisfied they were with their overall health care over the past year. 65% of patients who had an LIC student gave it the top rating versus only 43% of patients who did not have an LIC student involved in their care. So very concretely, in this study, a randomized trial, having an LIC student involved in care led to higher patient satisfaction scores. So one of the things I hear from faculty is concern that their patients won't like having a student involved in their care, that they won't be accepted. I think this shows us very, very clearly that this adds value to care, that our patients not only are accepting, but really see value in our students' participation. So you've heard me talk a lot about relationships. I'm going to keep going just a little bit more here. I'm talking about relationships between students and their patients, as well as students and their faculty. And that's because I believe relationship-based education really is at the core of what an LIC is. It's these relationships that allow us to think even beyond the LICs when I'm thinking about frontiers in medical education. It allows us to really get to the core of what a competency-based assessment is, to think about time variable education, community-based education, handoffs that are meaningful across the education continuum. And it also brings us to thinking about how we can meaningfully impact wellness in our learners. As McKenna and her colleagues described in their academic medicine commentary in 2016, connection to colleagues, patients, and the profession of medicine is fundamental to learners' resilience and overall well-being. The drivers of disconnection are actually exactly what I was talking about in the beginning when we were talking about the healthcare system factors that seem to be driving students into their observer roles. Things like shift work, duty hours, limiting time for connecting with patients and colleagues, the electronic medical record that has us spending all our time looking at a screen rather than looking at our patients. And this work-life balance that we spend so much time talking about that really just has us emphasizing the time off rather than the time on, where we actually are spending time with our patients and our colleagues in a meaningful way. So how can we combat this and think meaningfully about wellness? I think we can actually do it with many of the strategies that we've designed for our LIC programs. where we can create a sense of belonging, fostering of relationships, and creation of safe spaces for discussion and debriefing. So one of the relationships I haven't tapped into yet in this discussion, but that I've come to think about as being one of the most important aspects of the LIC model is that which develops between students and their peers in our small learning communities or cohorts. In 2018, in academic medicine, Ziegelstein and colleagues wrote about the importance of creating structured opportunities for social and curricular engagement to prevent student burnout. Connection, engagement, and group identification seem to be critical. The top photograph here is of the Denver Health LIC students serving up breakfast at a local teen shelter on a very early Saturday morning. And below are students participating in a reflective writing dinner focused on professional identity formation in my living room. So I think this is the connection and the community between learners we're seeking. And then finally, the relationships between students and the community are uniquely enabled during an LIC curriculum. Students are placed longitudinally for the entirety of the year in a single community or in a single healthcare system. This allows opportunities for alliance, service, and advocacy. So how better to have our students really learn and understand the social determinants of health, barriers to accessing care, and the needs and priorities of our communities. The first photograph here is of a high-rent hotel visited by our Denver Health students as part of a community health assessment. The intertwined importance of health and secure housing, I just don't think can be taught from the hospital, but only from the vantage point of engagement with community. The middle photograph here captures a student advocacy campaign at our state capitol. And the last photograph here is of a student foot care clinic at our local syringe access center. All of these service and advocacy efforts were sparked when students were working with their longitudinal patients and identified a unique care need through their relationships and the trust they developed with those patients over time. And so, with this evidence-based vision, I want to lead us back to talking more concretely about the CU curriculum reform. We call this curriculum the trek. So our students are metaphorically climbing a mountain from the plains to the summit. Our clerkships, or the LIC year, is now in the second year, which we call the foothills. All of our students are in LICs. These LICs are divided into 16 learning communities and scattered across our healthcare systems and across the state of Colorado. Each LIC strives to create a small learning community for the students with a dedicated faculty director and staff coordinator, and each has a specialized curriculum related to their practice site. Each LIC functions independently in recruiting faculty preceptors that are dedicated to their group of students and developing a curricular focus. But each is still responsible for comparability and clinical objectives of their content related to our core specialties and clerkships. I've thought a lot about resilience over these last 2 years, as I'm sure you have as well. The pandemic challenged our plans for developing this new curriculum, and we have rebuilt more times than I can count. The curriculum we launched last year is far from the perfect I imagined, but I actually think that's the key point about making real change. Perfect is no longer an option. No curriculum is perfect, and ours never was. I believe we'll continue to stumble, get back up, and revise. However, our vision to truly enact change in the way we educate physicians of tomorrow and therefore deliver care to individual patients and entire communities continues to push forward. I posed a question in the beginning about our crossroads. Which road should we take? The LIC movement and our move towards competency and relationship-based education has been the latest great shift in the history of medical education. I believe LICs are the future, not only here at CU, but nationally. LICs have allowed us to move undergraduate medical education back towards relationships, apprenticeship, and competency. If we've learned nothing else these last 2.5 years, it should be that our students need the resilience to face an uncertain future. We need to train them effectively, scientifically, and humanely to serve patients and communities first and foremost. We must advocate for the change that will allow our students to thrive and be the best possible doctors they can be. I think this is necessary not only for our students, but also for our faculty, and ultimately for all of us. We are their teachers, but also members of the society that will ultimately be served by them. So thank you. I appreciate your time and your attention. I'm happy to answer any questions. Hopefully I left enough time for that.
Okay. Fair enough. We'll repeat. So we don't have a traveling mic today because they are broken. So we will repeat the questions and I'll go be a megaphone around the room. So the first question I'll start with is, and I want to think Jen and I have met, I don't know how many times about this, answer both of them. So what about, so that's a common thing, we know how students are graded now. What's the assessment process look like in this?
Yeah, so the question was, what about grading and how are our students assessed in this model? So our students are enrolled in specialty clerkships across each of the core 7 specialties, as well as in an LIC course. And so they will receive assessments or evaluations, as they're sometimes referred to, from all of the faculty and residents that they work with. So if we take internal medicine as an example, they will receive assessments from the teams that they work with on their immersions, from their longitudinal preceptors at set points during the year, and then anyone that they encounter working with longitudinal patients. Those are brought together with their assignment grades, their shelf exam scores, all that is compiled and graded by a committee that is led by a faculty member that's now called a clinical content director, somewhat akin to a clerkship director in the past. That committee ultimately assigns a grade, and we are still on an honors high pass grading scale. And that process will play out for all 7 specialties. With the honors high pass grading system, our LIC course encompasses a number of the other aspects of the LIC course and is pass fail. He might be, yeah. You can ask. Great. Mhm. So the question was about the magnitude of change for the academic measurements and then also for some of the non-cognitive measurements. So I'll start with the academic measurements. Those are variable. I think some of the national studies have shown non-inferiority. So if we take, like if we took the internal medicine shelf exam, nationally in LICs versus traditional blocks, we're not going to see a significant difference. So whether you're in an LIC or a traditional block, there's not a significant difference. And I think that was sort of the key question in our adoption of this model. We wanted to make sure we weren't harming our students. So when you implement a new curriculum, you want to make sure that you're not hurting their knowledge acquisition. I would argue that the test is probably not the best measure of clinical performance at the end of the day. There are a lot of concerns about using standardized exams to measure even knowledge acquisition. But at the end of the day, we're not hurting our students. What we actually showed here locally at CU in our early pilots was that our students in LICs performed better than our students in block rotations. So I think we felt even more confident that we weren't causing harm to our students by adopting this model. In terms of the scales we use for empathy and patient-centeredness, those are validated scales that are used not only in medical education, but in other education fields. And so those are statistically different since they are not necessarily specific to to medical education, I should say. It's hard for me to translate that directly, except that we do know that when students start at the beginning of their clerkship, there is no statistical difference between students who are randomized. At the end of the clerkship and then 6 years beyond, there is a statistical difference. in that Harvard study where they randomized their students. So what was really unique about that program, when they first started their LIC, they were the first big program in the US to do so. So they took all the students who were interested in doing an LIC model and actually randomized them. So they have tons of interesting data that's come out of that program where we actually have the ability to look at it from a randomized standpoint. Here at CU, we have continued to replicate that using those same two validated scales, and shows the same thing. Our students have higher empathy and higher patient-centeredness scores, but at least in our early LICs, in particular the Denver Health LIC, our students went through a fairly competitive application process to get in. So that's always sort of the critique, is that the students who you chose that are just going to be more empathetic anyway. But we have been able to replicate those findings with our non-randomized sample.
Very helpful to understand the rationale.
Yeah, so specifically about the physician scientist pipeline. Yeah, no, I think that's a great question. So the question was about the bioscience pipeline. There are some really interesting studies looking at this right now about the pipeline in general. That's certainly something that I've been interested in from my own Denver Health cohort, looking specifically at the sort of urban underserved pipeline and whether we can get students who ultimately sort of marinate in that environment and then are interested in coming back to practice in that. There's quite a bit of literature from rural LICs. Most of that's actually coming out of Canada and Australia, that they have been very successful in recruiting physicians back to that environment. We have thought very intentionally about the physician scientist pipeline and the need to serve that and to sort of nurture and foster that. And the way we've designed, I'm going to go back to one of these slides here. The way we have thought about that is we have one of our LICs here at University Hospital that takes 22 students, LIC number 2 on this diagram, actually has that in mind. So its focus is inquiry. And our MD, PhD students funnel preferentially into that program. Because it's at University Hospital where the majority of our physician scientists are, we can intentionally match them with mentors and with preceptors who are interested in that pathway, partnering very closely with our MSTP training program, with the idea that each of these programs sort of has their own focus. That's sort of the point of having these different learning communities, that each one has their area of focus. But we've got a program with 22 students in it each year that is specifically focused on that curricular area. So in terms of long-term looks around the country, I don't know that that's been done. I think that's one of the exciting things about what we're doing here. We're first. So Dr. Sarah Fabel is leading that program, a physician scientist herself, and I think is really excited to look at that potential pipeline. Mm-hmm. Great. So the question was about our extended learning time and how that actually works, if I can summarize it that way. So you're right that this program requires a lot of self-directedness and advocacy for one's own learning. So what I will say is it's a little bit of both. So the student is responsible for developing their own cohort of patients, and part of the pass-fail grade that Jeff was asking about earlier in our LIC course requires that they have filled out their cohort of requirements by the end of the year. Our students meet with their directors at regular intervals to check on their progress. So we do have some guardrails around that to ensure that they've made that progress. On any given half day, we expect our students each week to be looking ahead and say, where do my panel patients have appointments? And how am I going to get there? The reason we are staffed up to have a staff coordinator for each one of these LICs is to help with some of the logistics around that. So the chances, I'm going to go back to that slide actually, the chance that any given student has their particular patient, like let's say they have a pediatric patient that has a cardiology appointment on Wednesday morning. That would be lucky. The chances are more likely that they have it on Thursday morning. And so they'll work with their coordinator to potentially move that surgery clinic to Wednesday morning so they can free up Thursday morning to go. So there's a lot of back and forth. We call this their skeleton schedule, with the understanding that any given week is not going to look like this, that there's a lot of shuffling around. So the coordinators are instrumental in making this actually happen. So I would say it's student driven, but faculty and staff supported to actually make the day-to-day happen. Great. So the question was, how does this model impact our residents? So I am really glad that somebody asked that question. So that's one of the things that I really wanted to bring forward to this group. I think our residents, especially in this department, are fabulous teachers, and I'm excited to be able to present this and make sure our residents are not only aware of it, but are thinking really intentionally about how they can support our learners. I think the easy answer to this is when I think about the immersions, now that all close to 200 of our medical students are in LICs, the way the immersions spread out across all of our major teaching hospitals means there is always an immersion student on a team. So the sort of day-to-day, a medical student showing up on your team is going to look very similar to the old model. Incorporate them in rounds, assign them patients, have similar expectations. And also recognize that at the end of their 4-week immersion, if they are not where you would expect them to be, knowing everything about internal medicine, don't worry, they still have the rest of the year with their preceptor. And we'll be back following their longitudinal patients. So I think it's a little bit of a frame shift in terms of our expectations around their goals and their objectives, and what they need to achieve. But they should be all in teaching our students the same way they always have been and providing that excellent education. The part that's new is when a student shows up, hopefully they've communicated ahead of time, they're supposed to. Hey, I'm following Mr. So-and-so, he was admitted to your team. Think about that as an opportunity. These students theoretically know these patients better than anyone, better than their PCP, because they followed their care trajectory for the entire year. They should know everything about their family, they should know everything about their medical history. See that as the opportunity that it is, and embrace them into your team. They may not be able to be there when you round because they have to go to clinic, but they'll be there early in the morning, or maybe they'll come over lunch. Use that as a resource. So have them teach them a little bit, but have them tell you what they know. They can help with discharge planning. So when was the last time you needed a PCP appointment, and they could make it happen tomorrow? They have like a direct line to me as the PCP, and I'm happy to overbook them because my LIC student wants me to. So I think they can be a real asset to your team and your patient care when they come in with longitudinal patients. Yeah. Yeah. Thanks. Yeah, I'll go to that slide too. So our decision to move clerkships to the second year was certainly based on what a lot of medical schools are doing around the country. So this sort of goes into the broader question of what else have we done in our curriculum reform. I obviously have focused much on our LICs. One of the other fundamental changes was our decision to shorten our basic science focus. So we have not cut out fundamental basic science teaching. What we've done is try to identify the critical basic science content that students need to be effective clerks, and then moved a lot of that to the post-clerkship phase. So what is in green here in our advanced science courses. So the idea being there that students can learn some of these advanced science concepts, basic science concepts, better when they have a scaffolding. So I remember sitting here at the University of Colorado many years ago, for 2 whole years, learning a lot of basic science that was really advanced and didn't make a lot of sense, and then promptly forgetting it. However, after I went to clerkships, I was like, oh, wait, I remember being told something about that, but it was in a vacuum. So the idea being that if we teach them what is truly foundational, and then they go see some patients, they will come back to us with scaffolding and a lot of great questions, and then have the hook and the reason to want to know and to learn those really advanced concepts. So it is sort of the interdigitating of science, clinical, and then more science when they actually have the clinical context to make the science matter. So that was the main reason. We also, together with this change, have moved step 1 after the clerkships, which at the time was very evidence-based. There were a number of schools that had made that change and showed a significant improvement in step 1 scores when step 1 was administered after the clerkships. The caveat there is that after we made that decision, we were far enough along that we couldn't really make a change back. Step 1 went to pass fail, so it's unclear if that was the right decision to make, and we'll continue to evaluate that. As I said, we're under a constant state of revision and rethinking our decision. All right.
Yes,
I'm just going to click to the end here.
Please.
I will leave with a couple of resources up here if you're interested in more. Thank you so much for your time today.